Welcome, everyone. We're so glad to have you with us on our penultimate session for our first virtual learning session. We're going to be talking about the planning that's going on for Phase 3, which is improving care and outcomes for individuals with Fontan circulation. And I'm really happy to be joined by Stacy Lynn, Alicia Wilmoth, Adel Unisai, and Jeff Anderson. Next slide. We thought we'd start with hearing from parent and patient partners about why this work is so important. Stacy?
Thanks, Carol. I just wanted to share some perspective from the parent perspective about why Phase 3 work is so important. My daughter Zoe, her pictured there, and then her sister Emerson and my husband Caleb. Zoe is now 5 years post-Fontan, and I've heard people say before that we now age our Fontan kids by how many years they are post-Fontan. We've had a pretty blissful and fairly simple post-Fontan life thus far, but as the years go by, that bliss is slowly fading. And it's really easy for us as parents to think, you know, once you reach that third surgery, you're done. That is typically the goal that we set in our mind because it's the last surgery out of the staged palliation. But once you hit that Fontan spot, you know, it becomes abundantly clear that that is not the case at all. In fact, post-Fontan living and research is, in a sense, pretty much uncharted territory. And the unknowns and not having concrete answers from science is both worrisome to parents and clinicians. But through my work with Sisters by Heart and in talking to parents across the country, it's clear that there is significant variation in what parents know and understand about being post-Fontan, not only from the physical side, but also the emotional side of the coin. I'm sure that many parents have seen, and some clinicians perhaps, online and social media when parents post questions about post-Fontan. For example, you know, my child is just had their Fontan. What is the follow-up care? Or how often does your child get labs drawn after the Fontan? And in the comments, you get anywhere from, oh, we get, you know, blood draws annually to, gosh, my kid's 3 years post-Fontan and hasn't had a blood draw. Should he have had a blood draw by now? And what is it for? So, you know, we see that there is little to no information or support in this area or standardization. And of course, you know, you see so many issues come up emotionally, and we had the resiliency breakout about the emotional and behavioral issues that come up, and schooling and anxiety hurdles that really were not focused on at all and really should be. So Phase 3 is hugely important, not only for looking at the physical side of things, but the emotional side as well. And we really need to have a focused lens on what the true issues are, what's causing them, identify the outliers, and finding answers for our children who are growing and will continue to grow into adolescents and teens and adults, and for our families and our siblings who are walking this Fontan life with us, being able to identify that. So I'm really looking forward to hearing Alicia's perspective and Adel and Jeff on what we're about to do with Phase 3 work and the importance to everyone. Thanks.
Thank you, Stacy. We're going to hear from Alicia Wilmoth now. And Alicia, can you, I know you've talked in front of NPC before, but you might remind people who you are and what you do.
I have to unmute me.
You're good. You're good.
Sorry. So my name is Alicia Wilmoth. I am a 38-year-old unbalanced AV canal with pulmonary atresia and heterotaxy, and I currently practice as a pediatric cardiothoracic surgery physician assistant here at Children's Hospital. I want to thank them for asking me to speak again, but I am truly passionate about this next phase. And I would second everything that Stacy had to say. some of the things that I thought about, if you could go to the next slide, as you can see, there's a navigation through life. Everybody goes through life, and we need to learn how to navigate those waters when we grow up with CHD. And as you can see now, I have children, so it's not so much anymore about, just me. It's about our siblings, our families, and soon to be our children who have parents with congenital heart disease. We have to continue to remember to recognize that Fontan physiology is not a fix. I'm thankful for the steps that have gotten me here, but it's not the end. And I'm not prepared to just live with a what if answer. I like to see more knowns, much like Stacy talked about in the mental health region, and just having surveillance measures to know, how to keep me sustaining, just like my peers. And then finally, as some personal notes that I feel as an adult living now is that for me, the biggest part is education. This is one of the greatest collaborations I've seen where we're all educating each other. As patients, it's not easy to sometimes listen to these things, but it helps us to be knowledgeable and to know how to help the practitioners do things. And so in addition to that, as an adult, we're no longer being seen in pediatric hospitals. And so there's a big fear of mine stepping into the adult world as to what iatrogenic complications may come from somebody in an emergency setting or elsewhere. So I think it's super important to be educating not only our cardiology and cardiothoracic surgery, but outside practitioners as well. And finally, I just think that it's been amazing to see the pioneering that Blaylock, Towson, Thomas, Glenn, and Fontan all had, but we're at a step in our lives where I'm ready to see the next name. And I don't care if it's a patient or a provider or a parent, but I think that's the time, and the time is now.
Thanks, Alicia. Thank you, Stacy and Alicia. That was terrific. I want to ask Adel, who is at Children's Hospital Colorado. Well, he's actually at home right now, and is also co-leading with Jack Rychik one of our phase 3 work groups, the Physical Health and Functioning Work Group. And Adel was going to give us some background on some of the clinical aspects of why this is important, building on what Stacy and Alicia have shared. Thanks, Adel.
Yeah, no worries. Thanks for everyone for the opportunity to speak. It's a little chilly here in Colorado. We've got about 2 inches of snow on the ground. So welcome to spring in Colorado. Next slide, please. I don't think anyone could have done better than Stacy and Alicia did in setting the why for why we need phase 3. If you look at some of the numbers, and this is a graph from Australia, New Zealand, and their database there, which is one of the most complete databases that we have right now in the world of individuals with Fontan, you can see the growing numbers of survivors with Fontan over the decades. Next slide, please. But what we're finding as children are growing up to be adults is that they're probably not fixed. I think they are normal, because I think the word normal is very polarizing, but they may not have the same opportunities that other kids do. There may be some limitations. We're just finding out what children and adults with a Fontan circulation can do, and we still don't have a good answer to how long will individuals with a Fontan live. Next slide, please. The Fontan circulation, I think most people by now realize that it's very, very different than a normal circulation. I think Jack Rychik put it at the NPCQIC once that we've really created a new kind of human being in a sense. And the assumptions that we use in medicine for someone who has a normal circulation don't necessarily apply to the individual with a Fontan circulation. That has pervasive effects on the lungs, the liver, growth, development, exercise, and that's just scratching the surface for what we know. And the more we look, the more that we find that things are different, and that the challenges and the complications in someone with a Fontan circulation are unique to those who compared to someone who has a normal circulation. As a result, given the increasing numbers of individuals surviving with the Fontan and the growing complexity, people have started to create single ventricle quote-unquote survivor programs or Fontan care programs across the country. They're just kind of in their nascent phase and are at different levels of sophistication, but people are starting to realize that you really need to have a special focus and a different approach for this particular physiology. Next slide. A little bit about our journey at Children's Hospital in Colorado. I think we began to recognize this as time went on. We started pulling these kids into a more separate care paradigm. It starts with fetal diagnosis and counseling. Of course, like many of the centers on the call today, we have what we call our complex congenital heart disease clinic, which is really that neonatal interstage focus with very intense follow-up and home monitoring. But we branched out and decided we were going to have, for certain patients where it made sense, more of a continuity clinic that involved a nurse coordinator and a nurse practitioner. It's not all of the patients in our practice, but there's a subset that come into that clinic. And then about every 2 to 3 years, we encourage our colleagues to send us all of the patients with Fontan circulation for a more multidisciplinary 360-degree evaluation, including pulmonary medicine, neuropsychology, psychology, and from a wellness standpoint to talk about anxiety, sibling relations, and family stress, as well as liver and GI evaluation. And then now we're working on our Fontan adult congenital heart disease, which is something that we'll continue to promote. We're not the only program that's done this, as I mentioned. Places like CHOP, Stanford, and several others have these programs either up and going or under construction right now as we speak. Next slide, please. But when we set out to set up our program, we really wanted to do it like we do all things in medicine by saying, where does the information, what does the science tell us? What do we need to check and how do we check it? And what we found is that there's very, very little data. Traditionally, we've had very few studies, and those studies tend to be on 10 to 20 patients from one institution, which is really hard to generalize. So the reality is there's much more that we don't know than what we do know. We don't know exactly what to check. We don't know how often to look. And oftentimes when we do find a problem, we don't know exactly what to do about it yet. And since, even though the numbers are growing, each institution follows a relatively small subset of these patients in the tens or maybe 100 or 200 patients. We really need to work together to have the power to understand what happens with the quote unquote natural history of the Fontan circulation. Next slide, please. So we started doing some work centered out of Colorado, but really it's multi-institutional in nature, where we sent out a couple surveys. One, we surveyed a bunch of different practices to say, what are you doing? And these are actually Fontan clinics. And then we followed that up, and I'll share some of the data from our most recent survey, which is where we've identified experts. And experts, these are the people who are working with the NPCQIC, they're working with the American Heart Association, they're working with some of the other groups, or have expressed a specific interest or specialty in Fontan care. So next slide. These are a representation from the different hospitals. There may be more than one practitioner from each of these hospitals. Next slide, please. And what we did is we offered up a long catalog list of different tests that could be performed in the care and surveillance of someone with a Fontan circulation. And we asked the specialist to say, would you consider this test class 1, which is highly likely of clinical value and really should be done in all patients? Class 2, which is perhaps not as highly impactful as class 1, but it's likely of some value. Maybe you don't need to do it in everybody, but it'd be reasonable to do in all or some patients. And then class 3, which is, it might be valuable, but really this is more in the realm of research. And we need to look at this one. And although it has some promise, we're not ready to suggest that other people should be doing it yet, or doing it in everybody. Next slide. We would then divided testing, because really I think it's a different approach, whether you're talking about very young children who've had their Fontan relatively recently, adolescents, or adults who are over 18 years of age. Next slide. And I'm just going to show you a little bit. There's a ton of data that we generated, but this slide is looking at the younger children. The next 3 slides will look at the younger children. And what we've done is taken the tests and divided them by where the majority voted them in. So these are the tests that the experts thought should be class 1. And if you hit the next slide button, I think we'll highlight a couple. Yep. So not surprisingly, the test that really everybody does, because we know them as cardiologists, we're comfortable, is an echo and an EKG. So about once a year, it's pretty typical for every child to get an echo and an EKG. And I think for the parents on the line, that's probably pretty familiar. If you could hit the forward button again. Thank you. If you notice cardiac MRI, which probably, to be honest, gives us a lot more data, but it's a lot more expensive. is kind of falling. It's barely in class 1. If you look at the percentage of folks, there was about just over 50% that felt that it should be done routinely, but not as popular as the EKG. Next slide. Liver elastography came up as class 1 because I think everyone agrees we have to look at the liver, but we don't have a good way to, we don't know a lot about how to look at it. And we're just learning about liver elastography. But of all the liver testing, I think this is one of the most popular ones to look at, and we're going to have to work together to learn whether it's as valuable as we hope it will be. Next slide. And if you could advance one more time. Class 2, so these are the ones that are somewhere in the middle, and you can see, looking at the different colors, that there are a lot of different opinions about these. And this is where cardiac catheterization lands. So I think our experts felt like it was a reasonable thing to do. However, the majority of folks didn't feel like it was class 1 and should be done on everyone. Why is that? Well, cardiac catheterization is more expensive, it's more invasive, there's radiation exposure, and so now the risk is going up. When we're not sure that information, if we're not really sure that information is going to be valuable, there are still people who don't feel that we should be doing it in everybody. On the other hand, cardiac catheterization right now is the test that gives us the most information about how the Fontan circulation is doing from the inside, as opposed just to see how people are doing on the outside. Next slide. Finally, we have the class 3 tests, which are in younger children. And again, I'm not going to go through all the age groups because we just don't have time. But for example, these are the ones that people still feel are, we don't have enough evidence to justify. And probably the most important one to notice is circled, which is liver biopsy. Liver biopsy has really been the best, we have the most evidence about liver biopsy to understand the chronic changes that are happening in the liver and the risk for cirrhosis, and even in adults now, there have been reported cases of hepatic carcinoma. But liver biopsy is still something that needs to be investigated more. Next slide. I think that's the end of my introductory section.
Thanks so much, Adel. That I think is really helpful and shows both the need for more research and some discussion in the field about what can we suggest might begin to be a minimal data set or some standard intervals for work to be done. What I'm going to do, and I just want to remind everyone, I'm not a cardiologist. I'm going to begin walking through where the 3 work groups are and what we've done for phase 3. We may have shared yesterday, and I think we did in Chicago, that we had our initial NPC design meeting surreptitious, or well, just fortuitously on the day of the eclipse last summer, the day of totality. So we think that marked a really exciting milestone. And what we did was come up with some the beginnings of a key driver, which we're beginning to, or we're continuing to work on. So if we go to the next slide. This is just to remind you what is happening in the network. Phase 1 are the boxes in the left middle, included all centers. Phase 2, which begins at the time of diagnosis, either prenatally or shortly postnatally to the first birthday, involves data from all centers, and the number of centers working across the 6 labs varies to some extent, but is continuing to build. And then where we are with phase 3 is that we have some small work groups, 3 work groups that are working in design. And one thing to share is that the design phase is iterative and messy. You develop some ideas, you work with them and refine them over time. And I'm always reminded, my kids when they were little liked the PBS series with Miss Frizzle. I think it was Magic School Bus. And she used to say, you have to get messy. And that's really what happens in design. So we're in this phase. It's early, but we hope that over the next 4 to 6 months, we'll be able to clarify what some of the initial data and work that we want to do is. Next slide. This was our initial key driver diagram, really pretty draft. Up in the upper left, it said that the global aim was to optimize longevity and quality of life for individuals with single ventricle congenital heart disease and optimize quality of life of the families. We ended up next, if you can click, as I mentioned, there were 3 key areas that we felt we needed to work on. Go back, please, thanks. Physical health and functioning, emotional health and resilience, and neurodevelopment. One of the key things to mention is that for those of you who've been a part of NPC for a long time, we really focused on patients with hypoplastic left heart disease. And so as we're moving into phase 3, we're going to be broadening the population that we'll be focusing on. And in the lower left, it says single ventricle congenital heart disease individuals who will undergo palliation and have Fontan circulation and or have undergone Fontan. So the idea is that we'd be enrolling patients, both those who are expected to undergo Fontan and then those who have already had a Fontan surgery. So I think how we'll work this out, whether it's staged, whether we try to begin this all at once, are some of the things we're going to be discussing and over the next several months. Next slide. So where we are, and again, this is the iterative and messy part, is that we're in design work groups focused on emotional health and resiliency, neurodevelopment, and physical health and functioning. What we do is typically write a charter, which is 1 to 2 pages that lays out what we want to do. We focus on our aims, develop measures, look at the evidence, and develop our initial theory of how we think we'll drive to outcomes. Next slide. So I just want to walk through very briefly where we are. And one thing I'll mention is we've had some individuals who have stepped forward and are working on this. If you're interested in participating, please send us a note at info@npcqic or in the chat box so we can follow up as this begins to broaden and as we want to get some feedback. The work group leaders in the CARES, this is Cardiac Resiliency Work Group, include a cardiac nurse practitioner, parents, and pediatric and adult psychologists. So again, really trying to look at the broad lifespan of individuals with Fontan. Next slide. Some of the measures, and for those of you who were in one of the resiliency groups, these are some draft things we're thinking about is the % of visits where emotional health is discussed and or information provided, visits that include screening and assessment at specific intervals, not every visit, number of patients and families with a risk identified, and then care centers who have mental health professionals that are working closely with the cardiology team. So again, some draft ideas as people are working on this. Next slide. This has always been an incredibly active work group developed for phase 2, different bulletins for patients and families. And here in the lower right is an example of the bulletin for phase 2. This group has already begun work on bulletins based on the domains that you see on the left, which focus on here's some things that you may be feeling, here's some things that are going on, some guidelines, and then across the top, the recognition that these need to be developed based on ages. So as I mentioned, those are already beginning in development. So really exciting that we'll have some of this available soon. Next slide. The neurodevelopment work group consists of cardiologists, parents, and a developmental, behavioral pediatrician. I want to note that Brad Marino, who is leading CNOC, the Consortium for Neurodevelopmental Outcomes, I think I'm missing one of the letters there, is very much involved with this, so we can really align with some of the work that's going on there. Gil Wernovsky, who's been a terrific advocate for this, is also involved, and we have patients and parents involved there as well. Next slide. Very similar to what the patient or the resiliency group is thinking about. This group is looking at domains versus age spans. Next slide. And here is where they are and where their group is working. Considering continuing some of the work that's going on for phase 2, for example, with developmental screening, but thinking about what goes on later, thinking about how to integrate this with the AHA AAP guidelines for high-risk populations. And there's some overlap here with the CARES resiliency group in that behavior section, and the social functioning. So we'll be working to link those. And that group has come up with this and is wanting to think, how do we prioritize what we want to do and collect. Next slide. And then the physical health and functioning group is being led by Adel and Jack Rychek. Kurt Schumacher from Michigan has recently agreed to also be involved. And we have Tom Glenn and Alicia who are involved in this group. Stacy comes on often. And then Travis Lewis is a parent from Pittsburgh and also a PA. So it's great having him involved as well. Next slide. The group here has talked a lot about what would be the appropriate outcome. And we recently sort of settled on increasing the functional status of individuals with Fontan circulation and promoting physical wellness. Some of the measures are in draft form. And I think, as you'll hear from Jeff Anderson and Adel, I think what we'll be thinking about is what would be some minimal data on this that we want to collect. As Adel mentioned, we want what we're suggesting to be evidence informed, and there is not a lot of evidence now in this area. So we recognize that there may be a set of variables that we collect across all the NPC centers, and then there may be some subgroups that will want to collect some more detailed or additional work. So again, we're learning a lot, and what I look forward to is we're going to be learning together. Next slide. So we want to talk about some complementary activities that we think will inform phase 3. And I'm going to ask, I think the next slide is for Jeff, and then we'll go back to Adel.
Yeah, so thanks, Carol, and thanks, Adel and Alicia and Stacy. I liked Carol's comment that this was messy. I think a little history is probably worth mentioning in talking about going forward to phase 3. Many of you will remember that the story goes that when this collaborative was started, the cardiologists who were beginning this journey worked with Carol to decide what quality improvement project within cardiology to focus on. And single ventricles were chosen as a population that we thought we could improve outcomes with, because a lot needed to be improved. But the group of cardiologists chose the interstage because it was a small area of time that the cardiologists had complete control over. They actually actively chose not to involve the surgeons at the time because not because we didn't like the surgeons, but because we had control over this ourselves. And so it was a several month period of time. And when we expanded to phase 2, Jim Tweddle says this often, that we went from this small defined area of the interstage to the entire first year of life. And it becomes now like drinking from a fire hose, not only in the data that we're collecting, but also in the complexity of the outcomes that we're trying to improve. As we move to phase 3, the messiness gets even more messy, because we're not talking about diagnosis to first birthday. We're talking about improving outcomes in an entire life span. The other reason it becomes messy also goes along with the journey that we've been participating in. The cardiologist, as I said, focused on the interstage because they had all control there. When we expanded to phase 2, we got new partners, which was awesome. We got surgeons and intensivists and fetal cardiologists, and all along the way continued to expand our partnership with parents and now with patients. And that's great. One of the foundations of who we are as a collaborative is that we believe in collaboration. We believe that we need each other to come to the right answers to these questions. But it becomes more complicated. Now we have multiple work groups, and it administratively is a little bit more challenging. Well, as we move to phase 3, and we start thinking about long-term Fontan outcomes, not only does our patient population expand, not only does the type of providers and experts that we need to do the work expand, we need more partners, but now we are interacting with other groups that are very interested in Fontan outcomes. So in a spirit of collaboration, we are looking for opportunities to work with other groups, clinicians, researchers that are interested in Fontan outcomes, so that as we create this registry of information about our patients and also the methods by which we're going to improve those outcomes, we're not duplicating efforts. And this falls right in line with this concept that I mentioned yesterday of Cardiac Networks United. So this is one group, Cardiac Networks United, that is trying to bring together many different organizations so that we can work together to improve our outcomes. In this example of Fontan long-term follow-up, Carol mentioned a couple of these organizations. One, of course, is us, the NPC-QIC. Brad Marino is in the leadership of the Cardiac Neurodevelopmental Outcomes Collaborative, which will be a part of us coming up with the right metrics around neurodevelopmental outcomes. Kurt Schumacher is involved significantly with the Action Heart Failure Network. As we're thinking about physical health and functioning, we want to make sure we involve our heart failure colleagues. I was on the phone last night on the way home with one of the physician leaders of the adult congenital groups within the United States, at least, who is very interested in how we're going to approach Fontan data collection and Fontan follow-up and improving outcomes, because obviously the adult congenital population of providers needs to be an important partner in all of this. So we are grateful in NPC-QIC to take the leadership role in trying to bring all of these groups together. And we believe that by doing so, we will create something that's better than if we were doing it on our own. And we'll also improve the efficiency of the way that we're interacting with patients and with families and with centers that are all collecting data to try to help us to improve. So I think I'll stop there. But to let everyone sort of who believes in and loves NPC-QIC as an organization know that we as leadership, as we move forward into this next phase of understanding and improving long-term Fontan outcomes, we intend to be incredibly inclusive of these other partners, but at the same time maintaining the integrity of what we believe is the right approach to how we work together to improve outcomes. And I think we can do that.
Thanks, Jeff. If people have questions, you can put them in the chat box, and we're going to have Adel go through a few other complementary activities, and then we can open this for questions to Stacy, Alicia, Jeff, Adel, or myself. So Adel, back to you.
Great, thanks. Yeah, I think Jeff put it well in saying that we have to be very, very cognizant that we're not the only one, the only group that has interest in this space. And I'll just go through briefly some of the high-level things, and some of you may have heard of these, but people who are new to this call or haven't heard me go through this before may not. Internationally, there's a group of folks that have gotten together that are now known as the International Fontan Interest Group. And the good thing is that there's a lot of people who cross boundaries, who are involved in different organizations. Standing right there in the middle in the bright sunshine and sunglasses is Jack Rychik, who also kind of co-chairs the physical health and functioning with me. And Jack is one of the kind of founding members of this International Fontan Interest Group that was really getting an interest in bringing people together a little bit more from an academic scientific standpoint to say, how do we work together to understand the Fontan circulation more? And for anyone who knows cardiology, the people standing in that group are kind of a who's who of international cardiology. They're continue to work on a scientific statement. They're interested in developing a risk score so that when you're young, you can try to predict who's at high risk for failing with the Fontan or developing specific complications. Similar to what we're doing in trying to get data collected across the collaborative, they're working on an international registry. Yves Dudicum, who's standing right next to Jack in the picture, is kind of the key stakeholder in the New Zealand, Australian registry, and they're working to expand that registry and include centers from all over the world. And then they're also trying to focus on punctual small projects such as valve replacement in Fontan and pregnancy in Fontan, just for a couple of examples, to do a deeper dive and understand. But it's all about collaboration on the international level. Next slide, please. We got a bunch of people together here in Denver last spring, just over a year ago, to start asking similar questions. How can we start to collaborate? How can we bring our data together? Again, this rule is really born out of our own personal experience that I mentioned earlier of being frustrated that we're trying to set up a program but not really having a lot of guidance. And so these are some of the other folks who have identified programs in very different forms, depending on how they practice and what their demographics are. But we all came together and said, how can we work together so that we can either start doing the same things, or if we're not doing the same things, comparing practices to better understand. And so we started working on some of the surveillance, and NPCQIC was part of that meeting. And I think now those kind of agendas have kind of merged. Next slide, please. Right now, there's in progress is a statement on the care of the Fontan within the sponsored by the American Heart Association, that will be published in circulation. I think there are a lot of people who are waiting for this. Just to be clear, this will be a statement. It will not be a position paper. There will not be a lot of recommendations on how to care, how to test a patient with Fontan. There'll be a lot of information given about that, but it's really not a recommendation paper. And I don't know if Jack's on the call or in the meeting, but if so, he's one of the co-leaders of this initiative, and maybe he can speak to it during the question and answer session. But that we're hoping will come out later this year or early 2019. Next slide, please. And there's a lot more going on. We've already mentioned CNOC and endeavors in adult congenital heart disease, where they're looking at long-term outcomes of the liver, where liver disease becomes even more of an issue. Pregnancy, how well pregnancy is tolerated. And then there's a pediatric heart network, I want to mention, who has, although they're not looking inclusively at the whole population of individuals with Fontan, they're doing a lot of great research where they've taken small projects, and small is relative. Again, I mentioned we used to do a lot of studies with 10, 20 patients. They're looking at 500 patients per project across about 7 or sometimes more institutions. So we're really starting to get some good prospective scientific data to better understand what's happening with these patients, at least in brief chunks of time. Next slide. And I think that was my last slide.
Thanks so much, Adel. That was terrific, and thank you, Jeff. There are a few comments, one of which I'll just point out that someone, I believe from Utah, said they were glad to see Jeff in his Utah shirt.
Go Utes.
Go Utes. Are they playing today?
So the only activity today that I know of is that the National Gymnastics Championship is today, and Utah
Do well?
will be in that. They will do
Okay.
it.
Okay. I just want to say at some point we'll have to have a session just on various sport loyalties. So
Yeah.
tend to come up here, but not today. So thank you, Linda, for that comment. So Sherry, you said there were some other questions, one for Adel, and I know we've gotten some things about people wanting to connect to the group. So we'll take all that and then be following up with you on that.
Yeah, and one question was just how do we let you know that we're interested? So you could put it in the chat right now.
Mm-hmm.
You can always email info inbox. So Adel, I believe this question's coming to you. Can you clarify what the frequency of serial assessments were recommended? So I think this was back to earlier when you presented, i.e. MRI and liver.
Oh, how frequent those things?
I think it's
You mean
Yeah.
in the surveys? Yeah.
Unfortunately, the short answer to the question is no, simply because we don't know how frequently we should be doing these. And I think that's part of the message is that we don't have good evidence to suggest that to really know how to look at the liver. We know the liver is congested with the Fontan circulation. We know that sometimes that congestion can lead to fibrosis or scarring in the liver. If that scarring gets severe, it can start to lead to dysfunction of the liver or cirrhosis. We think that this is probably something that everyone's at risk for and probably progressive. There have been a few studies out of Philadelphia that suggest that the only thing that really tracks with the liver disease is time from Fontan and age, which suggests that it's probably a chronic exposure to the Fontan circulation and congestion of the liver. But we really don't know what the best way to look. The data that we have is based on liver biopsy, which is obviously very invasive and carries risk. We don't even know the exact way to do a liver biopsy. You can do it from the inside during a cardiac catheterization, or you can do it from the outside, what they call percutaneously or through the skin. And there's differing liver experts who have differing views on what type of test to do. So we're just starting to gather knowledge. Same thing with MRI. MRI is more expensive. For young children, it requires general anesthesia, so it's typically not used in very young children. In older patients, you can lay in a tunnel and hold their breath when asked to, which is the majority of people kind of over 8 to 10 years of age. We can use that tool a little bit more effectively. But we don't know whether doing it yearly or every 3 years or every 5 years is the right answer. I think the reality is that there's going to be a smaller number of institutions who have large populations that are going to have to start looking a little bit more frequently and then find the answer and then adjust our practice on a national level. But that's where the collaboration really starts.
Okay. Thanks, Adel. Gail, are you on? And I don't know if you're muted. Jim Tweddle's behind me, an unusual thing here. So Jim, Gail's here. You thought Gail might have a
comment about this.
The frequency, yeah. Jim Tweddle just wondered if Gail had a comment. Gail may be muted, but I don't know.
We're trying to locate her.
Well, you're finding her. In the ether.
Here we go.
Okay. Hi, Gail.
Yeah, you'll have to unmute on your side. You've got her on our side.
Yeah. You're muted, Gail.
Okay. Here, let me just chat. I can't chat. I'm not muted from my side. Good morning.
We can hear
We
you.
can hear you.
But to answer your question, Jim, I agree with Adel. I don't think we have clear data on that surveillance. I think that most people would agree that there should be greater surveillance across greater domains than having a simple echo once a year for the next 10 years throughout older childhood and into adolescence. Our adults, when we started our comprehensive program here, my adult congenital colleague jokingly said, if you could get them to me at the age of 21 with something besides an echo for the preceding 15 years. That's my low bar ask to start out with, because that's what most patients are coming to me with at this point. They haven't had anything addressed with their mental health. They haven't had anything addressed with their liver or seen a hepatologist. They haven't seen a nephrologist. They haven't had neurodevelopmental screening at any point for their school or for their other functional status. So I think there's a lot of domains that we recognize now should be getting looked at some kind of interval. The group that Otto has led in the discussions, just to share a little, the discussions are that we probably should be looking at this in around 3-year epochs for the patients. So, what do we need to do for a kid around the time of school entry? And that'll look like a little different surveillance matrix. What do we need to do for the kids that are kind of, 8 to 10? And that might have a different mix of things in the mix of which specialists that they see along with the cardiologist, or which diagnostic testing they may undergo. What do we have as sort of, junior high kind of time, and then the late adolescence with probably some enhanced surveillance because there's some other issues that come up, and then a lot of important work around transitions of care. So I think that's a framework that the groups that have come together have been discussing. But what the specifics of that look like, I think we do need to do a lot more research. And I hope that we in NPCQIC will continue to lead that out in a collaborative way with our multidisciplinary partners and patients.
Thanks, Gail, and Jim, thanks for bringing that up. One comment that came up was, as NPC moves into phase 3, will there be increased costs? And I think one of the things I'm not going to have a definitive answer. I think main answer is we hope not, because we know that sites across the multiple networks that Jeff mentioned are getting maxed out in participating in multiple efforts. And I think one of the factors leading to the Cardiac United effort is, how do we share data, share work so that we're being more efficient and not costing more money. So, one of the things we've thought about is we're getting phase 3 designed and up to speed. We know we'll need some additional funds. Often when you develop the database and you get the analysts coming up with the charts, that costs some money. But over time, as we saw happen with phase 1, some things in phase 2, we're already seeing that some of the emotional health and resiliency, some of the neurodevelopmental work is going to begin to merge. So we really hope we'll start to see some transitions of work, or things that go across and are additive in terms of value to people. Jeff, do you want to make something?
I would fully agree with both of those statements. I think that the short answer, obviously, is we don't know, but we are making every attempt to make the cost of what we do less expensive. And part of it is working with these other networks to try to be more efficient so that each network has lower cost structure than they currently have. But it's also our job, I think, as the central team to make the argument and tell the story about the value of the work that we do, so that centers will want to not participate, though there is some cost to it. So we're working on ways that we can tell that story back to the centers so that they understand the incredible value of the work that you all are doing.
Thanks, Jeff. I'll just make a comment too that Jeff, has an MBA in addition to his other titles, and he was doing some back of the envelope work yesterday, and we're going to pull this together, but we're feeling pretty good about this first virtual learning session. And we recognize that this actually saved a lot of money for NPC and for the sites. We also recognize it couldn't have happened with much of the foundation that we've built over the years, that people know each other, are willing to come on. So I think we're trying to continue to figure out how do we bring value and make things work and continue to get the outcomes that we've been able to achieve. Again, I'm not a cardiologist, but when we started NPC, there was uncertainty among the 7 key leaders that helped with that. And similar to what Adel presented, there was significant variation about discharge, when babies were seen back in clinic, how babies were fed. There was really a lot of uncertainty about what to do. And I know that that can be paralyzing sometimes, that we think, well, we can't go forward unless we have all the scientific knowledge. And sometimes by bringing groups together, the work Adel has done to get people thinking about this, sharing what they're doing. And I think, as Gail said, there's probably some minimal, what's the word I want? I want to be careful about recommendations and guidelines, not that, but at what intervals might we begin to bring patients back? And what would be the minimal amount of data that is reasonable to collect? So I think there's a lot of work that we can do just to begin to answer some of these questions and connect with families. So Stacy, I saw you come back on. Anything you want to say in here?
Yeah, thanks, Carol. I just wanted to point out, and I'm certain that a lot of the parents and patients on the phone, while we understand and that there's a lot of question, and for us it comes out in frustration that, you know, there isn't data there. And I know that Gail and I have talked about this several times, that, you know, we're at this point and we have adults living with Fontans, and we don't have these answers yet. And to us, it's just truly frustrating that there aren't answers. And I think that that's why there's huge value in having patients and families involved in this phase 3 work, just to ensure that, you know, we're covering the emotional side of things and having that open communication. I think that will really help patients and families not only cope with not having answers yet, but being part of the solution, and taking control over these unknowns. And I think there's huge value in that. So I love seeing all of the patients, and I've gotten so much feedback just from today's sessions. But having that continued involvement in patient engagement is going to be really important.
We totally agree, Stacy. We wouldn't be where we are today without,
Right.
you know, this close relationship with Sisters by Heart. So, and now adults by heart, Alicia. So, so yeah, whatever. We'll start something. So, okay. Any other comments?
I would like, may I make a comment, Carol?
Of course.
Well, I would say to the patients and parents that are out there in particular, and I also think there's a tremendous number of, I don't even know what other disciplines, nurses, nurse practitioners, we had speech therapists, physical therapists. There's a whole lot of teammates that have been able to join in this virtual session. And I think having those teammates voice the value of this model within their center and at the national level, because there is a lot of positive energy and momentum right now in this arena for the late single V follow-up, the Fontan circulation follow-up, and a lot of work that has happened in the past in cardiology and cardiac surgery has happened in a model of a kind of traditional registry that looks quite different than what this learning health model looks like. And I think if the patients in particular feel like there is great value to that for them along with their clinicians, that's very important for the community of cardiologists and cardiac surgeons to hear right now too.
Jim Tweddle is shaking his head just off camera. So yeah,
I concur. Yeah, it was.
And as one other plug for that, you know, I had a long talk with the folks that run the New Zealand and Australia registry. And as a, for example, and this is a little out of the box for the US, but I'm going to put it out there, they have actually adult patients who are respiratory therapists, physical therapists, nurses, doctors, do a lot of the data entry for that registry. That's a model that's completely outside the box as far as I know of within the US, but that has allowed them to scale up and get to having a very important impact very quickly.
There's nothing like that for participants with skin in the game.
Exactly.
Yeah. And Jeff is just mentioning HIPAA, but I'm sure we can figure some of that out. That's a great idea, Gail. So,
well, I asked him about HIPAA things, and actually, Eve said that most of those they are doing it in a volunteer in terms of their time, but they are healthcare professionals that already had whatever the Australian
that city training that you can get.
confidentiality.
Okay, that's
We're willing to undergo that because of the skin in the game.
That's great. That's great. Okay. Jim, thank you for being here. And Sherry, should we send it